So hello everyone, and so we are going to discuss about special considerations for intestinal transplantation in infants. First of all, I have no potential conflict of interest, and second, this webinar is a team perspective on the subject. So we're going to go through indications, then when comes surgical considerations, and finished with few slides of immunological considerations, if there are any. We will discuss about different type of transplantation: isolated intestinal transplantation, either simple or modified with when you add the stomach, and intestinal transplantation, including the liver en bloc, bowel and liver, or multivisceral real with bowel, stomach, and liver, and most of the time pancreas and duodenum associated. First of all, I would like to start by watching you that basically for infants in our historical list of transplantation represented around 25% of the patient. But what you can see is that as time goes by, the number of patients listed for intestinal transplantation, no matter with or without the liver, has dropped drastically around 2010. And so what are the indications at this age, less than 2 years old? The real question is, are there any at this age? And regarding isolated intestinal transplantation, it's, at least for us, quite sure that there is few indisputable indication, but not anymore as in the past. Why? Because TPN results are far better than intestinal transplantation. That has conducted to a paradigm shift in most of the teams doing this transplantation from transplant to parenteral nutrition. This is comforted. It's not moving. I think I need to wait. This is due to the fact that in our hands, at least, the result of home PN at 10 years are far better than the result of isolated intestinal transplantation in terms of patient survival. It still remains patient with real indication, those with impending vascular access loss for PN, repeated life-threatening line sepsis, of course. But the real question that we need to answer is it a failure to rescue as a team that conducted the child to this condition? In France, we have debated around that, and we came to the conclusion, and it is written in the law, that children and adolescents under 18 years of age that will need long-term PN dependency, more than 3 months, should be referred to one of the seven PN certified centers in the country. So team dedicated. This policy has changed drastically our results in terms of PN management. As you can see, we have reduced drastically the number of catheter-related infection over time. In the late era, we only have something like 0.9 catheter infection per 1,000 days of use. The child we use 2.2 Broviac during his childhood as an average. But even that, we still have some patients that will die, of course, but or that will require specific attention to their liver because of intestinal failure associated liver disease. But those figures are dropping over years, first era, second era, and so on. So early referral is important. Important why? Because we can use rehabilitation process in order to increase the results of short bowel syndrome on long term. On the principles of this rehabilitation that will conduct inevitably to bowel adaptation with time, you have PN à la carte, what is completely dedicated to the child and not already prepared PN, manufactured PN that you can find for long term. This PN is also cycled, and that will conduct to harmonious growth and development. We have, with time, adapted lipids solution and understand that discontinuation of this lipid infusion is important with time. We work a lot on prevention of septic complication on those children, line infection with catheter lock solution applied each time the catheter is accessed. We do manage bowel dilation to avoid bacterial overgrowth with efficient stoma, lengthening and tapering solution. And we do manage long segment Hirschsprung disease in terms of stoma and excluded bowel. And I will develop on that later on. And the last point, which is extremely important for us, is to avoid continuous enteral forced feeds for bowel adaptation with time. From this last point, from all these points, what we know now for quite a long time is that intestinal failure associated liver disease will be induced by disadapted PN formula, forced feed for us, repeated infection, IV line, or translocation from stenosis or dilation of the bowel, or eventually from excluded bowel of long segment Hirschsprung disease. This condition will induce the need for combined intestinal and liver transplantation. Might conduce to this transplantation. Regarding aggressive tube feeding, what we believe is that in a bowel already injured by a congenital condition or other conditions like Hirschsprung or enterocolitis, to force the child with tube feeding will induce nausea, vomiting, abdominal pain, which is the bed for translocation, and then eventually liver disease with cholestasis that will progress until cirrhosis at one point. In the other side, this poor intestinal motility due to dilation with abdominal distension and erratic bowel movement will induce mucosal tears that will reduce absorption, increase permeability of the bowel, and decrease trophic factors secreted naturally by this bowel in a physiological condition. The child will develop food allergy, eating difficulties, poor growth, and poor intestinal growth. Oral feeding has the advantage of the self-regulation. The child will eat what he can eat without nausea or pain. He will then adapt his mucosa to these feeds, increase the absorption of nutrients and trophic factors, reduce his feeding difficulties and increase the intestinal growth. This is time for gut recovery and adaptation. And of course, if gut is doing well, the liver will be well. When we look at this study that we performed comparing a cohort from Calgary and one of a cohort from our center, what you can see is that regarding feeding difficulties, with the same patients and the same conditions, we do have less feeding difficulties in our cohort. Of course, some of the patients will still require tube feedings because of complete food aversion, but they are far less than the one in Canada. The big difference in the two teams is that Calgary is using very early and very long enteral feeds via tube rather than oral feeds. Another point of interest for surgeon is management of lung segment Hirschsprung disease. There's a point on those patients of prevention of sepsis, repeated sepsis. For that, we need to have a functioning stoma. This stoma will be ideally put in a ganglionic part. Sometimes it's not possible because you have a total aganglionic bowel from esophagus to anus. And what we have seen is that putting them on the first jejunal loop, anyway, with gravity, the child will have bowel movement permitting oral feeds with pleasure. But we need to keep in mind that by growing, he will grow this aganglionic bowel as well. And at one point, we will need to put the stoma upstream if nausea, vomiting episodes recur. The second point in this very specific population is the discussion of subtotal enterectomy of the bowel downstream the stoma. What we have seen with time is that the risk of enterocolitis associated with this excluded bowel is maximum after 2 years old. So now we have changed the way of manage those children as well. Most of the team in Europe don't perform the subtotal enterectomy in the neonatal period. And we used to ask as a transplant team to keep this bowel in order to avoid an empty abdomen for the time of transplantation at one point, but which is not anymore the case. We do list those patients for subtotal enterectomy around 2 years old in order to avoid repeated episodes of sepsis. So early referral is important, but at one point you can still ask why not, because there's the fear of doing worse. You have seen the figures, but the most important thing is to consider the fact also that with isolated intestinal transplantation, you can still go backward and remove all the transplant. But for all those type of transplantation, including the liver or modified multiviscera, you cannot remove all the intestine graft in case of acute rejection. You will have to keep one part of the graft. That means keep the child on immunosuppression with the risk that implies. It remains, of course, for isolated intestine transplantation indication, some pending questions. Are we sure that they will become P independent at one point? And for the what we call type 1 small bowel syndrome, like Hirschsprung disease, no colon, just direct stoma of the small bowel. Will it be stoma forever? How will they manage that as adolescent? And what about, of course, pan-intestinal forms, where sometimes they really struggle with nausea and sometimes abdominal pain. In this discussion of short bowel syndrome, the game changer has come from the GLP-2 analogs that are for some of us available now for those children. Indeed, Lamb and colleagues have demonstrated that in a group of patients around 9-year-old with a median length of residual bowel of 26 centimeters, that you can, with daily injection of teduglutide, reduce by 50% the PN dependency. That means for those children, less time on PN and days during the week where you can discontinue PN, and reducing the amount of PN as well. But as a surgeon, the real question is now, what if we were using this GLP-2 earlier in order to induce bowel growth? And there's a study by a Canadian team on mini pig model of short bowel syndrome, where they demonstrated in the pig that with daily injections of GLP-2 analogs, two types of GLP-2, a long-lasting apraglutide and a short-lasting teduglutide, you can increase the length of the bowel with a statistical significance. So why not neonatal use of those analogs? And we already see the best indication post-severe NEC, multiple atresia syndromes, early volvulus, and of course, long segment Hirschsprung, but with ganglionic bowel remaining. Before 3 years of age, because we know that the growth of the bowel will reach a plateau around 3 years old. So the maximum, the best window would be probably before this age. So after all that, are there still any indisputable indications of intestinal transplantation in infants? Yes. Combined liver and intestine, there's a room for patients suffering combined intestinal and liver failure. And we will have to discuss bowel, liver, or multivisceral transplantation. What are the conditions? Congenital condition, it's the child harboring a biliary atresia and a short bowel syndrome. In this situation, it's quite difficult to fix the liver with a Kasai operation because you don't have enough length of bowel. You can see that in multiple atresia syndrome or meconial peritonitis, very severe meconial peritonitis. Another condition, which is a syndrome, is Martinez-Frias or Mitchell-Riley, depending on which side of the Atlantic you are, where you have biliary atresia associated with multiple intestinal atresia and dysplasia of this bowel. Even if it's not short, it is not working, and an associated pancreatic failure. This syndrome is due to RFX6 mutation, which is a transcription factor implicated in the embryology of all this part of the embryo, liver, pancreas, and foregut. And we do have the nice experience of La Paz team, who did a multivisceral transplantation with success in a patient suffering this condition. The other option for a combined liver and intestine is, of course, all the secondary situation, and all of them fall into the situation of intestinal failure associated liver disease. And we should question all the time if it is, as a team, a failure to rescue. If we go now on surgical considerations, because transplantation time has come. The stages for a successful transplantation are multiple. There's the donor selection, is it the perfect match? The procurement and all the steps that we need to control, and the other teams as well. The transplantation stages that need to be mastered, and of course the postoperative management. If we go to donor selection, it's always a balance between the condition of the recipient and the bet that you do when you choose a donor for this recipient. It's always important to keep in mind that in the case of isolated intestine and modified multivisceral, it is always a relative life-threatening situation. When it comes to the liver associated, it's most of the time life-threatening, and you need to go fast and make sometimes some bet on different criteria. General criteria of the donor and anatomical considerations. Regarding general donor criteria, we do have quite large criteria that you can see on the left as compared to those of the US, for example, criteria. We will choose a cardiac arrest less than 30 minutes, as where they will have cardiac arrest less than 15 minutes. When we look at this, why is what is back this hemodynamic stability of the donor? We all know that the splanchnic flow is the fifth wheel of the carriage most of the time. And so this splanchnic flow will suffer a vasoconstriction in a donor with hemodynamic instability. These ischemic injuries can induce mucosal tears that will breach the epithelial barrier. If you add to that the ischemia reperfusion injuries by cold storage, you will impair in a way the graft and compromise this graft and probably increase the risk of acute rejection. However, with experience of some teams, we have learned with time that pediatric donor is quite resilient because they use pediatric donors after cardiac arrest from 1 to 52 minutes, and the survival are in their hands was more or less the same as compared to no cardiac arrest donor. That has increase in some teams this specific criteria on the donor. Regarding hypernatremia, there is no literature on for intestinal graft, to my best knowledge, but what we can think is that the increase of plasmatic osmolarity will induce, of course, endothelial and epithelial injuries. This can compromise the graft, and by increasing inflammation and immune cell attraction, increase the risk of acute rejection. So in our team, we keep the limit of 160 as sodium in the donor max. For transaminase, it's the reflection of the initial shock, so it has to be weighted according to the urgency and the cause of the death, of course. After a liver trauma, the donor will have increased transaminase, but that doesn't mean that the graft is bad. ICU stay is important because an infected donor will increase the risk of rejection in the patient. Cold ischemia is interesting. It's probably we are still trying to reach the 6 hours total cold ischemia, but it's probably a bit too stringent when we look at this study comparing enterocyte apoptosis in rat, pig, and human ileum. Human is in dark, and as you can see, even at 24 hours, it wasn't that bad. I'm not saying that you should go up to 24 hours, of course. BMI is important, but because the fat mesentery will not suffer a cold storage. When we go to anatomical considerations about this transplantation, the size match is extremely important because most of those children will have lose a part of their abdominal domain, and particularly short bowel syndrome with resection quite early in life, which is completely different in motility disorders where you keep the bowel quite longer. If you add the loss of abdominal domain and the graft reperfusion edema that we all face frequently, it's sometimes difficult to achieve primary closure. And the best situation is probably, the best match is probably the donor weight around half of the recipient weight. In order to achieve this primary closure. And when the liver is associated, it's not above 1.5 if you want to close the belly. If it is not possible, because sometimes because of donor shortage at this age, you have to proceed to a stage closure, which means that you will close the abdomen sequentially during 1 or 2 weeks by a system of mesh and vac eventually. The results of this approach are not that bad if you see the result of this team, where the sequential closure had the long-term survival even better than the primary closure. And all this approach needs to be known because of the balance of organ shortage and urgency of the patient, of course. The retrieval is extremely important because small recipients will need small donor, and those small donor have very fragile vessels. So it's quite easy to do intimal tears just at the retrieval if there's too much traction on the graft. The hemostasis has to be performed very carefully, of course. The vena cava of the small donor will be very thin and need to be careful when you retrieve. And when comes the time of the anastomosis, it's most of the time large anastomosis, so it's not a big issue. But sometimes the vessels are so short that there can be direct anastomosis can induce undue tension on the graft. It is that's important for the team doing the retrieval to come back with the graft and different vascular conduit coming from the donor. The best one for small donors are the jugular and the carotid, probably, if not the aorta and the vena cava. Last section is immunological consideration. Those intestine grafts are extremely immunogenic. So rejection is one of the main cause of graft lost in those patients. And rejection that could be triggered by infection or rejection directly triggered by injuries of the graft. It is so important when choosing a donor to have the previous history of your patient. Is it do you have some anti-HLA antibodies? Do you have history of multiple surgery, multiple transfusion? Is there a recent event that could trigger increase of those HLA, anti-HLA? And we do perform a virtual course match, of course, and we will adapt immunosuppression protocols depending on all this history. For isolated intestine, most of the time, if immunologic compromise is on the table, we will decline the graft. The immunosuppression will be quite hard. If it is a low risk, liver plus bowel and no donor-specific antibody. And if it is high risk, it will be quite important, the immunosuppression, as you can see, because you will try to act on all the aspects of immunity, and this is for isolated intestine, liver and bowel plus DSA or retransplantation. But I went through this nice study from the Pittsburgh team, I think, where they have studied the results of infant donors in terms of graft survival on long term. And as you can see, it's drastically different. Donor age less than 1 year, you have a graft, more than 10 years graft survival of 80%. And donor age above 1 year, you have a graft survival of around 50%. There's a little BA in the analysis of this study because those with donor age less than 1 were liver inclusive for 90%. Anyway, I think this study is really interesting. And I tried to go through the ITERIA registry data, asking them how many recipients less than 1 year were transplanted over years. It's not that bad. How many had donors less than 1 year old? Around 38%. And when you look at both recipient and donor less than 1 year old, it's only 12% of all the data that they have. And although non-significative, it seems that there's a long-term graft survival difference between the two groups, and this work should probably be further continued. What are the scientific data about that? What we know from a study from Pittsburgh is that the tolerance is driven by an increase of graft Treg population. And Columbia team has worked on 3 different pediatric donors, infant donors, and I've shown that in those graft, intestinal graft, and all graft also, you have an increase of this CD4 plus Treg population in the bowel, meaning that maybe there's a window to be studied for this intestinal transplantation, a window for the perfect balance between donor age and recipient age in order to increase our results with time. And maybe there's also a window to study machine perfusion in this in these grafts in order to increase even more our results. So as a conclusion, optimal PN management prevents ILFALD. Optimal neonatal surgical bowel management prevents EFALD. Future development in small bowel syndrome are probably GLP-2 analogs, and bowel growth means starting this treatment quite early. And in transplantation, probably there's a room to study specifically very small donors and their role in induction of tolerance, and in another way, machine perfusion role in optimizing those grafts. Thank you for your attention.